Well, okay, thank you so much for coming for Pharmacology 2, lecture number 3. And today we are going to complete our lecture about heart failure. Then we will talk about the antiarrhythmics, dysrhythmias. And then we will talk about what? About anticoagulation. Anticoagulation. Very important topics. Okay. All right. So this is one of my favorite topics, and they have a lot of clinical, a lot of nursing interventions, and actually, I want your help. Your participation is always needed. Okay, it's welcome always and needed. So please, okay. All right. So going to unpin myself. Why I cannot unpin myself? Okay, there. Okay. Oh, of course. The pen tablet. As always. Oh, okay. My God, I'm surrounded by a lot of papers. Okay. All right, so let's talk about heart failure. So please, what do you understand by heart failure? Tell me with one in your way. What could be the heart failure? And actually, you know what I'm going to do? I'm going to play stress. Yeah, so it's a long time when we don't play stress. So let's play stress, okay? All right, so the first on my screen is Miss Ana Arias. Miss Ana, please elaborate and illustrate us what is your definition, technical definition of heart failure, the best of the best you can. My microphone is off.
I'm sorry, I thought my microphone was on. I guess when the heart isn't working at its optimal um way, like you're not like I don't know, your heart rate is up, your systolic pressure is up, and then as yeah, I don't know, Dr. G. I'm stressed right now.
That's the idea. Very good, very good. Adriana, please, what is heart failure for you? In your own words. I tell I'm going to play stress. Huh? Okay. Nathaniel, you start to get ready.
Oh no, I'm fine. You want me to go?
Okay. Adriana?
Heart failure.
Oh, okay.
It's when like not enough blood is being pumped into the chamber, so you're not getting the adequate amount getting supplied through the body.
Why is that? So, what is the heart failing? Heart failure is when the heart is failing. Failing to do what? What Nathaniel was saying, to pump out blood. Right? So that is heart failure. So just listen. You still don't read the words. Heart failure. That is your answer. Is the heart is failing. Now you start to go to the next step and think what is the causes of heart failure? What is going to make the heart fail, Mr. Jacob?
Like not enough blood pumping.
What? Okay, so we are actually go in circles. So I'm playing stress, huh? So don't take it like personal. Okay, so I'm telling you, you're telling me that because there is no enough oxygen or blood supply, etc. So, but my question is, why is that? So that is what is going to happen during the heart failure. There is no enough blood pumping, right? So, but my question was, what can be a cause of this failing of pumping of the heart? Alejandra, you get ready after Jacob. Alejandra, Christian, get ready. Alejandra,
Is it
what?
my turn now?
Oh, sorry, what?
Is it my turn?
Yes, your turn. Yes.
Hypertension?
Yeah, hypertension could be in the long run. So I want you to write down this. When you have hypertension in the long run, they can produce hypertrophy of the right ventricle. Okay, write it down because somewhere you're going to use that. Always, when you have hypertension for long run, you're going to have hypertrophy, means an enlargement of the right ventricle, diminishing the lumen of the ventricle, so there is no enough blood pumping. That is one of the causes. Okay, give me another cause. Thank you, Alejandra. Very good. Christian and Jerel, get ready. What could be another cause of heart failure?
Is it diet?
Diet?
Yeah. Like what you eat?
What you can eat that can make you the heart failure? So what I'm assuming, Mr. Christian, is that yes, it's partially true, but the context I'm going to put it in context. You can have signs and symptoms of heart failure when you are malnourished, when you are very, very much malnourished, and definitely there is no enough blood in the body. So that is a type of heart failure. But there is a very common, that is the most common cause of death in United States. We have 700,000 people dying every year in United States. So it's like double of the cases of COVID-19. How many people die in the United States already from COVID? How much? Anna, you said 300? I lost the count.
A lot.
Too many.
Yeah, but definitely the number of all right. So give me another cause, Gerald, just to know.
Could it be
What can make the heart fail?
coronary artery disease?
Coronary artery disease can cause what? By the way, I'm telling you, you are the closest from all the class so far. What is going to cause
Blockage in
CAD? And cause what? They can cause what?
it can cause the heart to not pump properly.
Okay. All right. So, yeah. Okay. Good try. Very good. Charlize. Okay, Charlize. Charlize, Erica, you start to get ready.
The heart doesn't get enough blood.
Why you have the heart failing? The heart is, yeah, that is one of the, could be, yeah, that could be a cause. What is the consequence of the blood of the heart not receiving enough blood?
And it's not.
If the myocardium do not receive enough blood supply, what can happen? Okay, Erica. Okay, illustrate that. Take us
If there's no
out
enough
from the
blood,
hole. Huh?
if there's no enough blood, there will be no oxygen. There can be ischemic and infarction.
Oh, excellent. Everybody hear that? Why you didn't tell me that? You're smiling now that you said, oh, why I didn't say, why you didn't do it? You need to do it. Myocardial infarction. Myocardial infarction. You have myocardial infarction. MI, the MI. What is the MI? Tell me, what is infarction, Juliet?
The heart attack? What?
Yeah, but what is infarction? What is the meaning of
Um,
infarction?
I don't know.
What does it mean, infarction? So if we don't know that, we are barely going to understand what is heart failure. Anna C. Okay, go ahead. Yeah, there you are. Listen, she have the answer.
It's like the obstruction of the blood supply to the
No,
organ.
that is the cause of the can cause infarction. What is infarction itself? Medical terminology.
No clue.
Death of tissue.
Dead tissue. Infarction is dead tissue. If you don't understand that, the rest is going to be walking in the swamp. You are not going to go that far. So you need to understand what is infarction first. Infarction means the cells are dead. Dead cells. Infarction. Dead cells. Write it down that, please. You need to write it down because I was asking, you don't know. So you better write it down. Infarction is dead tissue, dead cells. Infarction is the same to say necrosis. Necrosis. Necrosis is dead tissue, right? So, but we don't said heart necrosis. We said heart infarction. Okay, depends how you talk, but mostly that's the way we talk. Okay, is that clear? What is before? What you do? You did EKG, right? So you need to know this. So before the myocardial infarction, the infarction, what happened? Just before.
Ischemia.
Who said that?
Charlize.
Charlize, okay, you're coming back. Yes, ischemia. Ischemia means low oxygen to the tissue or the cells. If that persists, the cell dies. So, for example, if you want to strangulate yourself. If you strangulate, you have low oxygen, right? So basically, if you are an organ, you are enter into ischemia. But if the ischemia, you're still strangulating yourself, well, you cannot kill yourself with strangulation. But okay, somebody is strangulating you. So if that persists, that get into infarction. Is that clear or no?
Yes.
Don't forget that. That is the main thing. So how we can do preload after load if you don't know that? All right. So now that is ischemia, and then it's going to lead into infarction. Okay? All right. So ischemia are going to have some reflections on the what? On the EKG. Okay, so we will talk about another time with the ST elevation, etc. No STEMI. All right, so we okay with that? So let's get started. So how much time is spending like this? So look, so please, I want you to participate more, please. All right. All right, so here we have a case, a 60-year-old, put the seatbelts, we are going to start. A 68-year-old woman presents with increased inability to sleep while laying down. So that is important. That is so characteristic of heart failure. In heart failure, the patient cannot basically sleep flat. They cannot sleep flat. They need to sleep with 3-4 pillows. They need to like a semi-sit position, semi-folder position, are going to be able to breathe. Why? Because the heart is failing. It's not sending enough oxygen to the lungs. So, and the oxygen is very low on your body. So what you're going to do is to try to sit up or put up your head with pillows in order to make more support of the diaphragm to deeper. So that is what is happening. So when you have a patient sleeping with 3 pillows, you're not going to think because they like pillows. No, because they cannot breathe. That is different. Okay? You okay with that?
Yes.
That is characteristic of heart failure. One, but remember, please, one forever. One sign or one symptom or one sign and symptom do not make diagnosis. You need to check the overall. So that's why exists the assessment. So you need to do all the assessment in order to actually get into a conclusion. All right, so you will see, as a nurse, you're going to check if the patient is having the medication, appropriate medication that is making them breathe better, so he can sleep flat now. He doesn't need any more of those pills, and that is to monitor, to evaluate what is the effectiveness of the medications on the patient. We okay with that? All right, so that is what we need to remember. All right, so 60-year-old elderly person present because have more risk to have heart problems, right? With the time, right? Atherosclerosis, hypertension, diabetes, hyperthyroidism, whatever you mentioned, whatever is related to as a risk factor. So I mentioned now the risk factors. Please think about a person that is your friend or close to you, somebody. So you need to recognize these situations. 60-year-old woman present with increasing inability to sleep while laying down, shortness of breath, SOB, and swelling of her feet and ankles. Why is this swelling of feet and ankles? Why? Why? Because too much fluid? Yes, too much fluid. But why in the legs? Guys. Erica, are you ready?
No.
Okay, good. So Erica, look. Here we are going to go this. Erica is going to be our star tonight, okay? Today. Okay, Erica? No?
Thank you, Dr. G.
Excellent. That is attitude. All right, so look at this. This is the lower extremities. This is the femoral vein. The femoral vein. And this femoral vein go here. They're going to drain the blood. So they're going to go to the common iliac veins. And what happened at the end? The internal iliac vein, external iliac vein are going to form the superior vena cava. Superior vena cava. Superior vena cava, sorry, the inferior vena cava. The inferior vena cava. So the blood is coming this way. Then here we are going to have the heart here. And the heart is going to, these IVC are going to end into the right atrium. Yes or no? Right? Yes or no?
Yes.
All right. So this right atrium is receiving the blood from all the IVC. If the heart is not pumping because it's failing, part of the muscle of the heart is dead. So can you run? Run. And I want to take half of your muscles of your thigh. I'm going to run right now and remove half of your muscles of your thigh. Can you run as before? Of course not.
No.
Right? The heart is not going to pump neither because part of the muscle is dead because of myocardial infarction, because the acute coronary syndrome that lead into stable, no stable angina or STEMI, no STEMI, and you have myocardial infarction. Infarction means that the muscle of the heart is dead. Depends which branches of the coronary artery are going to be affected, but that is another story. The thing is here that the heart is dead. Some tissue is dead. Some tissue can be dead because of the myocardial infarction. So what happened? This heart cannot pump to the pulmonary artery, to the lungs, cannot. So what happened is going to be flooding of blood here because they cannot pump out all the blood towards the lungs, But the blood is keep coming, keep coming, keep coming, keep coming, keep coming, keep coming. But you cannot empty the heart because the heart cannot pump all the blood as before out from the heart. So what happened? The pressures are going to increase in the right atrium. So because it's going to be more and more difficult to push blood into the right ventricle. Why? Because there is accumulation of fluid here that make increased pressure. So this portion is more difficult to get in from the right atrium to the right ventricle. So pressures are going to increase in the right atrium. And as a consequence of that, sooner or later, are going to increase the pressures in the IVC. Pressures in the IVC. So the blood that is flowing from the lower extremities and part of the abdomen are going to be more and more difficult, and the pressures are going to increase. And here, the veins of the lower extremities that are going to be contributing in the formation of IVC are going to increase pressure too. Are going to increase pressure. And what can happen with the veins in the lower extremities? Are start to distend. And what happened with this distension? Water start to escape. Water start to escape. Water start to escape. And the water by gravity, they go through the feet. By gravity, the water go down to the feet. So that's why you have lower extremities edema. Is that clear or no?
Yes.
All right, so that is going to be a sign of heart failure when you have edema in the lower extremities. Is that clear or no?
Yes.
Yes.
Okay.
Yes.
Physical exam reveals a small elderly woman with a slight respiratory distress. What is respiratory distress? Respiratory distress, you know that the normal rate is 12 to 20. Yeah, respiratory distress is going to be about more than 25. More than 25. Okay, so the patient starts to have some problems they have like hungry for air. So they are basically get anxious because they have lack of oxygen. So the patient is basically anxious, nervous, afraid. You're not happy. Oh, I need air. No, you are stressed out, right? All right. So her heart rate and respiratory rate are both increased. Okay, heart rate go up, not necessary, but they can be heart rate go up because the body is trying to compensate. So it depends the mild or moderate heart failure decompensation. But the heart rate in general, yes, is going to increase. There is distensions of her veins, her crepitant rails, and her both lungs, lower lung. Why you have crepitants in the lungs? What do you have crepitants? Oh my God, I go into. Why you have? What is a crepitant?
Crackling sounds.
What are crackles? What is making the crackles make that sound?
Fluid.
Fluid, and why that fluid get into the lungs?
Water escapes.
Exactly, why the water escapes from the veins? Because the pressures are going to be increased in the veins. And which veins we are talking about? Basically, we are talking about the pulmonary veins. Pulmonary veins. All right, so please, I need to talk about pharmacology, but I see that the signs and symptoms are not clear on you guys. So probably we need to do another extra hour, another time to talk about just heart failure. What about that? Because I can kind of concerned because you need to enjoy it. You need to love heart failure. It's not like memorizing. It's that bread and butter. Okay, so all right, so I'm going to start saying this here. Look at this. The heart failure. Heart failure can be divided into right and left heart failure. You can have infarction on the ventricles on the left side, or atriums in the left side, or in the right side. But the most common heart failure is the left heart failure. Left heart failure. So left side. So now, listen to this. The left heart failure with the time can lead into right heart failure. So you have the whole heart failing. So if you have left heart failure, with the time they get worse, and they can get, in addition, the right heart failure. Second, if you have right heart failure that is less common, but not uncommon completely, the right heart failure in the long run can lead into left heart failure. Okay? All right. So overall, wherever the heart failure starts, they can lead later on into massive heart failure. Now, number one. Number two, on the right side of the heart failure, one of the characteristics is the edema on the lower extremities. I said plural for the thing I just explained you. You okay with that? So right heart failure, bilateral lower extremity edema. Bilateral lower extremity edema. Now, Nathaniel, you are thinking about what happens if we have only one leg edema, right? And most likely that is not heart failure. Most likely when you have edema in one lower extremity, it means that it's most likely a DVT, a deep vein thrombosis. So you can differentiate that, right? So edema in one or two extremities. All right. All right, so that is on the right side of the heart. In the left side of the heart, what is failing basically is the left ventricle. The left ventricle cannot pump out the blood from the left ventricle. So there is no space for the blood that is coming from the left atrium. You got it? So the pressures are going to go up. The pressures in the left ventricle increase, pressures inside the cavity. The pressures inside the atrial left atrium are going to increase too. So the pulmonary veins cannot drain blood into the left atrium anymore. So the pressures in the pulmonary veins are going to increase, and that can produce escape of water. And that water are going to get into the lungs. And this water into the lungs are going to produce dyspnea, SOB, and crepitance. Why on the basis? Because the water by gravity go to the deepest area. Correct? Conclusion and summary here, and don't forget ever in your life. Right heart failure, lower extremity edemas. Left heart failure, dyspnea. Dyspnea. Okay? Parenthesis there, pulmonary edema. Pulmonary edema. Pulmonary edema. Pulmonary edema, the left heart failure. Okay? Parenthesis again. You can identify that the patient is having pulmonary edema when the patient cannot lay down flat. They need to sit up. That is called orthopnea. Orthopnea. You already know what is orthopnea, right? Okay. And they have cough. Cough, tinged with pink color. When they have a sputum and tinged with pink color, that is basically you're getting pulmonary edema. Just remember, one sign or one symptom is not giving you the diagnosis, okay? And you need to know that, because how are you going to make the patient feel comfortable? The patient having problems of breathing, you cannot make them flat. Be okay with that?
Yes.
All right. All right, so let's keep moving. I think I'm going to pass to the drugs because I think we need. All right, so you will tell me. All right. All right, so her heart rate and respiratory rate are both increased. There is distension on her veins, and crepitant rails are heard in both lower lungs. You understand now why is that. Her liver found enlarged, and there is a marked pitting edema in the lower extremities. Pitting edema. You already know what is pitting edema, right? So we explained that in a few moments ago. Is that correct? We got it?
Yes.
Yes.
Okay. Now, another thing that you must remember is this. Let me see, blue. So I will try to make it nice, well, as much as I can. Green, okay, no. I don't have to be insect. Okay, so here we have, this is the heart. This is going to be the IVC. The IVC. Okay. Then here we have the veins from the lower extremities, right? That are going to be the external iliac vein, then the internal iliac vein, the common iliac vein, and then at the end are going to form the IVC. That is at the level below the navel. If you put your finger, one finger below the navel, that is where it starts the IVC. All right. So now here I make it this draw because I want to make it like this. So the liver is here on the middle, right? So what happened, I will try to draw. Look at this. Here is the liver, and the IVC is going to pass posterior. So I'm going to put like a dot, like a dot. Yeah, the IVC is passing behind the liver. But the liver is going to drain what we call the hepatic veins. Hepatic veins. We have the middle, the right, and the left. Okay, hepatic veins. These hepatic veins coming from here and are going to drain into the IVC in this direction. We have 3 of these veins. So the liver is going to drain the blood into the IVC. So we have the IVC, and the liver is here, and the liver is going to contribute with the blood to the IVC, draining the blood from the liver to the IVC. We okay with that?
Yes.
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 So what happens when you have heart failure? In the heart failure, the pressures start to accumulate for the reasons we explained, and the blood of the liver cannot get into the IVC. So the blood starts to accumulate in the liver, and the liver starts to get enlarged, and that is called hepatomegaly. You okay with that?
Yes.
Yes.
All right, so please, okay, so if you don't have that, it's very difficult, you will understand heart failure. So the liver is going to be enlarged. Remember, the liver cannot be palpable normally. They're under the ribs, and you cannot pulp the liver. If you can pulp the liver, that means the liver is enlarged. Okay? All right, so let's keep moving. Why is this? Why? My God, there is so many things happening rare lately. Okay. All right. Her liver is found to be enlarged, and there is marked pitting edema present in lower extremities. X-ray reveals a heart be dilated and enlarged. I'm not going to teach you how. I'm going to show, if you want, at the end how to read an X-ray just in 2 seconds. You can tell the heart is large or small or normal. So another time. And there is a sign presence of pulmonary edema. Pulmonary edema. So in the X-ray, the X-ray, when there's water, you see white, totally white. That is, those whites are actually in the X-ray showing that is accumulation of fluid. Assessment of heart failure, most common complaint is progressive fatigue and SOB, walking a block. Before they was walking 5 blocks, 3 blocks, and now just going upstairs, they get so exhausted because the heart cannot pump enough blood to the lungs to receive oxygen because the heart is failing to pump. Orthopnea, because of the dyspnea. Need to sleep with many pillows. Paroxysmal nocturnal dyspnea. Wake up in the middle of the night. SOB is another minor, but it's actually a sign of can be heart failure. Right heart failure, bilateral right, put your hand on the right side of your body. Right heart failure, bilateral lower extremity edema, or ascites, or pleural fluid, hepatomegaly and splenomegaly. All right, I'm going to explain you about the hepatomegaly and splenomegaly in 3 seconds. Look at this. Look at that. Here is the liver. Here's the portal vein. This is the portal vein. Portal vein. Portal vein are going to drain blood into the liver, but the portal vein are going to receive blood from the splenic vein. Splenic vein. There's a splenic vein. And here we have the superior mesenteric vein. Superior mesenteric vein. So why am I doing this? Look at that. This superior mesenteric vein and the lower inferior mesenteric vein collect blood from the intestine, where it's coming all the absorption of the nutrients. So they're coming here, and they're going to go to the portal vein, and the blood is going to go to the liver. Now, the splenic vein, the spleen, are going to do the same, are going to send blood into the portal vein. So now, if you have heart failure, the liver is supposed to drain the blood into the IVC. But when you have heart failure, you cannot drain out the blood from the liver. So the blood starts to accumulate in the liver, start to enlarge the liver, hepatomegaly, but the blood that is coming through the portal vein is having problems too. They cannot drain anymore here. So what happened? There are going to be dilation and high pressure of the splenic vein, and produce at the end, accumulate the blood that is draining from the spleen to the splenic vein cannot happen. So what happened? So the spleen starts to enlarge. In heart failure, you're going to have those characteristics, liver and spleen. The liver can be enlarged, it's called hepatomegaly. The spleen can be enlarged, it's called splenomegaly. You need to, this is a finding that you must remember, because splenomegaly can produce risk for bleeding, heart bleeding. And if you have hepatomegaly, you need to check your LFTs, because the liver can be having into liver failure. All right. So the hepatojugular, the JBP. Do you talk about JBP in your class? Yes or no?
No.
The jugular veins. Jugular veins. Okay.
We talked about like JVD, but
what is that?
Jugular vein distension.
Exactly. Jugular vein distension. So please, this is the last thing probably we are going to talk about that. Okay, look at this. Now, please look at this. This is the heart. I'm going to make the heart here. This is the superior vena cava. Superior vena cava, draining blood into the heart. Okay? And you know that superior vena cava is formed by whom? We have, I'm going to put them blue. The superior vena cava is formed by the jugular vein, and is formed by the subclavian vein. So they are going to form the brachiocephalic vein here. So we have subclavian vein, we have the jugular vein, we have the brachiocephalic vein, and together with this is the right jugular vein, the right brachiocephalic vein, and they are going to join together with the other brachiocephalic vein, that is the left brachiocephalic vein, that is formed by the jugular vein, the left jugular vein, and is formed by the subclavian vein, the left subclavian vein. So these two brachiocephalic veins are going to form what we call the superior vena cava. Superior vena cava. Okay? So here we have here the superior vena cava here, and so you can see the branches here. Okay? Now, the IVC is coming here. The IVC is coming here. All right? And they are going to drain blood into the right atrium. But the heart is failing. So you cannot pump out. So there's a lot of pressures a lot of pressures here on the right side of the heart. So what happened then? So all this pumping, the blood are going to produce pulses that are going to be transmitted to the jugular vein. So because there is so much tension here, there is basically a constant communication with the internal jugular vein. So this internal jugular vein are going to basically what we call dancing, the dancing of the jugular vein. You're going to see boom, boom, and that is going to be in the semi-Trendelenburg. Oh, actually sitting in 45 degrees, in other words. So 45 degrees. Let's make it like this. 45 degrees. So you lay down, the patient is like this flat. And then you make the patients to see that 45 degrees, and you will see a dancing jugular vein. Dancing jugular, moving in each heartbeat. Now, I draw here the IVC. Why? Because if the lever is here, when you push the lever with your hand, this pressure are going to increase, making the jugular vein more evident. So that is the test where you can actually assess the jugular vein. I don't know if that's clear or not, but definitely that is clinical. Okay, I wish I could be in the school. I can teach you how is the maneuver, but the heart failure is very, very important. They have a very rich in clinical. All right, so let's keep going. All right, so laboratory data, we have cardiac markers, we have the troponin. Troponin is very important. So please, what are the laboratory tests? So listen, you need to follow your nursing process, your assessment, your clinical history, the present, the most important data, subjective, objective, the past, right? Family history, it can be contributing here. Then you go to vital signs. Your vital signs basically are going to be low blood pressure, heart increase rate, heart respiratory rate, right? Temperature, you need to check temperature because it could be a trigger from infections, right? So you always need to rule out that. Then after that, you do your physical exam. In your physical exam, what you are going to do is basically heart and lungs, lower extremities. So you are having risk for cardiac disease. So you need to remember what are the risk factors for cardiac disease. Risk factors are going to be, for example, sedentary life, are going to be obesity, are going to be high cholesterol, patients with diabetes mellitus, patients with hypertension, patients with smokers, drug abusers. So those are the risk factors. So they can actually, previous surgeries, stents. So those are something that you need to always investigate in the clinical history, cardiac disease. So that is the clinical history, and you need to remember what are the cardinal signs of heart disease. What are the cardinal signs of heart disease? So, all right. So, number one, what are the cardinal signs of heart disease? Just to be sure here.
Shortness of breath.
Yeah, there you are. SOB. What else?
Edema in lower extremities.
Edema. Lower extremity. What else?
Palpitations or tachycardia.
Palpitations, tachycardia. What else?
Dyspnea.
Huh?
How to say it? DYSPNEA.
Dyspnea?
Yeah.
SOB, dyspnea. What else?
Chest pain.
Chest pain. Syncope. What is syncope? Fainting. Why the patient can faint? For many reasons. One of the reasons, we discussed another class about that, but faint can be because there is not enough blood pumping to the brain, because the heart is not pumping. The heart is failing. Chest pain. Another could be angina. And in angina is chest pain. Palpitations, tachycardia. The heart is involving. Edema, lower extremity. Right heart failure. SOB, dyspnea, left heart failure. So you need to always remember that, please. Okay? All right. In the laboratory tests, there are going to be basically few things. Number one, so I'm going to just, number one, are going to be the AKG. AKG to rule out, you can see many things. You cannot really see heart failure there, but you can see other considerations like hypertrophies, like bradycardias, like enlargement of the cavities, etc. EKG. Number two, you need to go a lab test called the troponin. Troponin. I'm going to put here the lab test troponin. 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 Troponin is a protein that is located in the heart in the cell, cardiac cell, and they are basically a marker for telling you that the patient is having destruction of the muscle of the heart. So that is what happened with the troponin. Troponin is located too in the striate muscle and smooth muscle and the cardiac muscle. All of them is the troponin. Remember giant cat? Troponin is attached to the calcium to release the actin myosin and produce the contraction. So the troponin, in this case, according to the clinical appearance of the patient, basically the troponin can be having from the heart because the patient is having signs and symptoms of cardiac problem. Other problem of troponin elevation could be that somebody have a car accident and they have a massive destruction of the muscles. That is coming from the troponin too. But there is two different types of troponin, and the troponin that we measure is the one who is specifically located in the heart. So troponin, troponin, troponin. Troponin means already infarction. Troponin, in other words, means infarction. Okay, so elevation of troponin. Then we are going to have the BNP. BNP. BNP is the B natriuretic protein. BNP. BNP means the B natriuretic. So that means that they are going to eliminate sodium on the kidney. Why? These BNP are going to come when the heart cavities walls are too distended. Why is distended? Why? Because the heart cannot pump out blood from the heart. So the ventricles are going to be distended. And when this distension happens, the body is going to produce a BNP, the B natriuretic protein that produced is the elimination of sodium from the kidney in order to decrease the cardiac output and basically control the over-distension of the ventricle. Right, so BNP. In addition to that, you're going to ask, they need to be ready to ask the CBC. CBC is the complete blood count, including the white cells, including the platelets. Platelets, very important. Platelets are very important because the platelets are going, this value are going to be used as a baseline to, in order to administer, if that is the case, heparin. So you need to check the PTT, the partial thromboplastin time. And based on that baseline, you can have how much heparin the patient is going to receive. Okay, because we have a control. So the heparin is going to affect the second hemostasia, right? And the second hemostasia is going to be measured by the PTT. If you are going to give heparin, your PTT need to be in a certain range. So that's why you need to have a baseline of PTT at the very beginning. All right, so then you are going to have a lipid a lipid, what? A lipid lab test. But in conclusion, I will summarize here. Troponin, BNP, CBC, see you have TBC, right? And you have a complete metabolic panel. Complete metabolic panel. So those are the tests that you need to have on this patient. Okay? All right, so we okay with that?
Yes.
Yes.
Okay. All right. So we are going to talk about, there you are. See, this is the heart failure. So this is the portal vein. This is the portal vein. That is the portal vein. This is the portal vein here. Portal vein is here. This is the portal vein. This is exactly the portal vein. This is the right and left branches of the portal vein. But here we have the spleen, and the spleen is going to give blood supply to return venous flow into the portal vein. And all this is the inferior superior mesenteric vein that are draining blood into the portal vein. So this, if you see here, we have the hepatic veins. These are the hepatic veins. The hepatic veins drains into the IVC. So if you have some blockage in the IVC, it's going to increase the pressure here. So the blood cannot get into the right atrium. So accumulate blood, so the blood of the liver cannot drain into the IVC, producing a hepatomegaly. But this hepatomegaly is severe, that this is going to start being affected too, because there is no space to receive more blood into the liver because it's flooded with blood. So what happened? The splenic vein start to distend, and you have what we call splenomegaly. Splenomegaly. Now, if you have here the jugular vein here, this is the internal jugular vein, and the jugular vein are going to put it here, drain into the superior vena cava. If you push here with your hand, push the liver. So what you are doing is increasing the pressure here, increasing the pressure to get into the right atrium, increasing the pressure on the right atrium, and they are going to transmit the mechanical force into the internal jugular vein. And your jugular vein is what you call the dancing jugular vein. In order to make more sensitive the test, the patient at the beginning is like this in supine position. Now the patient needs to be in 45 degrees. 45 degrees in order to make that test. Okay? All right, so that is about. Now, here we have here we have the pulmonary edema. If you see here, we have this vessel, let's put it this way. Here we have these pulmonary veins that are draining into the right atrium. When this right atrium are not working, there's heart failure on the left ventricle, the blood starts to accumulate in the left atrium. So what happened? The pulmonary veins here, 2 on that side and 2 on the other side, they are draining. 4 pulmonary veins drain into the left atrium. 2 from the left, 2 from the right. So when there's too much pressure, the blood starts to accumulate here. They cannot go into the left atrium. So increased pressure, distended vessels, water start to leak, and that produces pulmonary edema. Conclusion: the right heart failure, lower extremity edemas. The left heart failure, SOB, pulmonary edema. Okay, we got it?
Yes.
Yes.
Okay. Now let's talk about some terminology here before to go to the drugs. We have what we call the venous return. Venous return. The venous return, what is the venous return? Is the blood coming or going towards the heart. And that basically is the IVC and the superior vena cava. But most important, or more, I would say 90% of that is going to be, 75% or more is going to be the IVC. So the IVC is the venous return. Imagine all the blood is coming into the right atrium. All the blood. Use your imagination. Blood that is coming into the right atrium, right atrium. That volume of blood getting into the right atrium is called the venous return. And this venous return is called the preload. 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 Preload is like you have a cannon, you're loading the bomb, whatever, right? That is the preload. You're preloading, and then you shoot, right? So preload is what is coming inside the amount of blood coming into the heart. Preload, preload, volume, 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 preload, volume, preload, volume, preload, volume, preload, volume. Is the blood coming towards the heart? Okay. Now we have the afterload. This is the afterload. The afterload is the force of ejection. Please, I don't want you to think that afterload is volume. It's not the volume. Afterload is when you are shooting the cannon, boom, outside, right? So afterload is the force of ejection. Force of ejection is not the volume. Afterload is the force of ejection. Is how hard the heart is going to contract. You okay with that? So preload is the volume coming in, and the afterload is the force of ejection. You okay with that?
Yes. Dr. G, can we take a break?
Yes. Yes. Thank you. But give me a second, please. I start to get. I was trying to. I mean, I'm getting already enthusiastic here. But anyhow,
Yeah, you were getting into your groove. I'm sorry. I didn't want to
that's
interrupt
fine.
you.
That's fine. So this is the last thing I want to tell you. Look at this. The heart is going to be like a rubber band. This is the heart. The heart, when it's doing, look at the volume of blood getting into my heart. This is the volume of heart. And they are going to do this, contract. But when you have more blood coming into the blood, the heart is going to distend more. Like a rubber band, you pull the rubber band, the more you distend it, is going to pull you back stronger, harder, correct? So the heart, when it's with this volume, is going to do this. But the heart, when it's having this volume, are going to contract harder. But there is a moment that the heart is not, is distended so much that what happened with the rubber band? What happened with the rubber band? It's going to get broken, right?
It loses elasticity.
Exactly. And that's what happened with the heart. So there is many factors that contribute with the heart failing. Myocardial infarction, over distension of the heart. Okay? So those are basically, but myocardial infarction is one of the most common. All right, so let's have a lunch break. It's lunch break, right? You're talking about lunch break, right?
Yes, please.
Okay, so I will see you at 11:35.
Thank you.
Thank you.
Thank you.
Hello?
Hello, Dr. G.
Hello, hello. Okay, so let's get into more deeper right now, and there is some, we are going to do some nursing considerations that are part of the interventions, part of your patient education and all that. All right. So, but before that, we need to talk about something to understand what is the concept of heart failure. Let's put it everything together right now. Ready? Number one, tell me one thing. You are sitting down, resting, or well, studying, focusing, etc. Right? So just try to let's make something different. Let's make a walk on the park. Let's walk in the park. Let's walk on the park, and actually you can tell that you are going to breathe normally. There is a walk. You don't even think about you need to breathe in, breathe out, right? But now suddenly you want to run. When you want to run, what happens? You start to breathe more deeper. Why you need to breathe more deeper? Why? Because you need more oxygen. Why do you need more oxygen? Because your muscles need more oxygen in order to do the activity. Yes or no?
Yes.
Right? So the key phrase is this: your body have more need of oxygen. More need of oxygen. That is the key point. Now, if you, for example, you are doing exercises and you are walking with a weight of 10 pounds on your shoulders, 10 pounds on your shoulders, you are doing some exercise. So you need certain amount of oxygen. But what about if I ask you to lift 60 pounds on your shoulders and you need to still walking? If you have 60 pounds of more pounds on your shoulder, your needs of your oxygen are going to be higher. Yes or no?
Yes.
Yes.
Okay. So now let's imagine something now. You are walking with 60 pounds on your shoulder, walking, and the 60 pounds on your shoulder, and you're walking normally. Okay, so with some need of oxygen because the weight, right? You need more oxygen. The muscle contracts stronger, etc. What about if I remove part of your thigh muscles? So one thigh, the right leg, let's put it this way, the right thigh, the muscles are not working anymore, but you need to still carry the 60 pounds. So that means that you actually need more oxygen, yes or no? Because you are going to compensate with the other side of your lower extremity to walk in the same rhythm and the same pace. Okay? That is the concepts that I want you to remember for heart failure. The heart failure is failing, like the thigh. Your leg is not working. So other part of your body or other part of your muscle need to compensate that. So what about if we decrease the load of 60 pounds to 5 pounds? So do you need more oxygen or less oxygen in that moment? Do you need less or more?
More.
If you decrease those 60 pounds
Less.
to 5 pounds,
Less.
you're going to decrease the needs of oxygen, correct? All right.
Yes.
So let's suppose that your leg is your heart. And the load 60 pounds is the volume of blood that you have in your body. All right. So if you have too much blood, too much volume of blood, the heart is going to pump harder or more easy. If you have much more volume of blood, the heart is going to pump harder or more easier?
Harder.
Harder, right? And making the heart work harder, the needs of oxygen are going to increase, yes or no?
Yes.
Yes, right? So just to make it simple now, for example, when you have heart failure, you cannot have overload of blood volume. You cannot, because that is going to make you need more oxygen for the heart to pump. The heart is going to pump harder if you have more volume. So if the heart is failing, let's make it easier, the job of the heart. What about if we decrease the volume? If we decrease the blood pressure? If you decrease the blood pressure, the heart will not need as much oxygen, and that actually is going to preserve the heart. Because if you actually have overload of fluids, the heart needs to pump harder, and the heart is failing. So tell me, if you force your leg to work harder without having injury in your muscles, you're going to have more injuries. Yes or no?
Yes.
Yes.
Right? And that is what happened with the heart. So now let's talk more technical now. In order to decrease so what is the conclusion here? We need to make the heart work easier. We cannot force the heart to pump harder, because the heart is going to suffer more lesions because they need more oxygen and the heart is failing. So that's why, what about if we decrease the preload? Can we decrease the preload? If we decrease the preload, that you already know, that is the amount of volume getting into the heart, if you decrease the preload, the heart is going to work easier. Yes or no?
Yes.
That's correct. Now, what about if I decrease the afterload? The afterload is the force of contraction of the heart. What about if we decrease the afterload? The heart is going to be working easier, yes or no? Right?
No.
Right or no? If you decrease the afterload, the heart is going to work harder or easier if you decrease the afterload?
Easier.
Easier. Everybody got that? Now, the preload and afterload are depending of each other. If you have less afterload, there is going to be less volume in the heart, and the heart is not going to contract that harder. But if you have a lot of preload, venous return to the heart is full of blood. So in order to pump all that blood out, they need to make more efforts. Yes or no?
Yes.
Okay. So now, we need to decrease the preload and we need to decrease the afterload in order to decrease the needs of oxygen for the heart. That is the goal in heart failure. Again, we need to decrease preload and afterload. Decrease both of them, preload and afterload, in order to make the heart work easier. It's not the same to carry 5 pounds on your shoulders than 100 pounds in your shoulders. So that the pounds, the weight is going to be the amount of volume of blood that is in your heart. So what we need to do is to decrease the preload and afterload in order to actually make the heart easier to work. And what does it mean? If we make it harder, the heart is going to have more damage. And what is at the end of heart failure? The end of heart failure is just a heart transplant. There is no other things to do. Right? So that's why you need to prolong to delay the progression of the disease, decreasing your preload and decreasing the afterload. You okay with that?
Yes.
Everybody's clear? Rinsing, are you okay? Rinsing, Miss.
Yes.
Okay, now, so our goals are going to decrease the preload and the afterload. What is the preload? Is the venous return. Now, I want you to put in your mind the formula that we already know very well. Blood pressure is equal cardiac output times peripheral resistance. Remember that?
Yes.
You know that if we increase the peripheral resistance, the blood pressure go up. Yes or no? Right? If we decrease the peripheral resistance, the blood pressure go down. Yes or no? Right? And the same thing with the cardiac output. The cardiac output is the stroke volume. And the stroke volume depends of the venous return. Means depends of the preload. The cardiac output depends of the preload. So how we can decrease the preload? We can decrease the preload, decreasing obviously the cardiac output. How we decrease the cardiac output? You know what is the cardiac output? Cardiac output is volume, stroke volume times the heart rate. Now, if you have more blood pressure, high blood pressure, tell me, the heart work harder or easier?
Harder.
Harder. If we increase the blood pressure, we harder. So what we need is to decrease the blood pressure. How? Decreasing the cardiac output, decreasing the peripheral resistance. You okay with that?
Yes.
So, as a conclusion, that is the treatment, the pharmacology for heart failure. So, what could be the solution for heart failure? Number one, you want to control the cardiac output. Decrease the cardiac output is going to increase going to improve the function of the heart. It's not going to work harder. So decreasing the cardiac output means that we are going to use diuretics. Diuretics are going to be one of the tools that we use for heart failure. Now, talking about the peripheral resistance. In the peripheral resistance, what you're going to do is to decrease the peripheral resistance. And how we decrease the peripheral resistance? Because we want to obtain less blood pressure, right? So that's why we decrease the peripheral resistance. And how we decrease the peripheral resistance? With vasodilators. Which vasodilators we have? Vasodilators will be, for example, alpha 2. Alpha 2 is a vasodilator. Or you can use alpha 1 blocker. Because what is doing alpha 1 is vasoconstriction, increase the blood pressure. So we can block the alpha 1 with alpha 1 blockers. And that promotes the vasodilation. And that is going to decrease the blood pressure. You okay with that? Simple, right? Simple. And all the signs and symptoms that we was mentioned before, you're going to use as to monitor the effectiveness of the treatment of the patient. Okay? So is that clear? Everything is clear? Jacob, is clear on that? Okay. So thinking, all right? Thinking. Very well. All right. So now, okay. So what is one of the main problems of heart failure? Okay. Sorry. Okay. Rinzi. What is the main problem of the heart failure? Listen to this. Don't forget ever this. The problems of heart failure is the retention of fluids. Retention of fluids. How the retention of fluids are going to happen? Look at this. Very simple. The retention of fluids are going to be fluids that are going to go outside of the arteries and veins. And why the water start to go out of the arteries and veins? Why? Because the pressures on the veins are going to be very high. And why the pressures on the vessels the blood are very high, actually is going to push the water out. So that's why we need to decrease the blood pressure in heart failure. Otherwise, are going to be retention of fluids. Where are going to be this retention of fluids? This retention of fluids is, for example, in the lower extremities. The blood cannot get into the heart. Why? Because the heart cannot pump out the blood, and the blood starts to float on the heart. So there are going to be flooding of blood in the heart, flooding of blood in the IVC. And this increases the pressure inside the IVC, making escape water into the lower extremities, especially on the ankles. Why? Because the water by gravity go to the most deep portion of the body, that is actually the lower extremities. All right. So that is one. Another one. You have that the blood cannot drain from the liver into the IVC. The liver cannot drain the blood into the IVC because in the IVC we have high pressures, because the heart cannot pump all the blood from the right ventricle. When the blood is not pumping out from the right ventricle, it starts to accumulate. So the blood that is coming from the right atrium are going to be more and more difficult. And it's going to start increasing pressure. And that are going to be transmitted to the IVC. The IVC neither can drain out blood into the right atrium. And the liver is draining blood into the IVC. If the IVC cannot receive blood from the liver starts to accumulate blood in the liver. And what happened? The portal vein, who is draining blood into the liver, are going to be jam of blood, because there is no more space in the liver, because the liver cannot drain into the IVC, and because the right heart failure is happening, they cannot make space for new blood coming, because the right heart failure cannot pump all the blood out, but the blood is still coming. So the portal vein starts to distend because they cannot drain the blood into the liver. And the distension of the portal vein produces high pressures inside, making escape the water into the abdominal cavity. And that is what we call ascites. You okay with that? So everything is like a plumbary situation, right? Flooding, if you cannot drain it, the water keep coming, the pressure increase, the water start to float and go everywhere. So now, and the conclusion of this is this. Look at this. Don't forget this ever in your life. Listen. Heart failure. HF. Hard. With HARD. Heart. F on fluids. So the heart failure are going to be hard on fluids. So the problem is that you are going to accumulate fluids in your body. Okay? And that is coming the first nursing consideration. If you are actually having problems for the accumulation of fluid in your body, one of the things that you need to make on the patient as intervention is the restriction of fluids. Fluid restriction. And you need, for that, there is many other things. You need to weight the patient, for example. And that's what we are going to see that in the next few slides. All right, so let's get started. All right, so here we have the, where is my pen? The preload and the afterload. All right, the preload is the venous return. It's volume. We are talking about volume. but the afterload is the force of contraction. So afterload is not actually volume, okay? Now, the venous return is like a rubber band. The more you distend the heart, the more you contract the heart. But the heart cannot work because have heart failure, right? Most of the common causes is myocardial infarction. So part of the muscle is not working. So what we need to do is to decrease the venous return and decrease the force of contraction, that afterload. Okay? All right, so let's keep moving. All right, so now here we have another mechanism where you're going to see that when the heart is failing, basically the blood pressure are going down. The blood pressure is going down. So you cannot pump because the heart is failing. And that produces accumulation of fluids because the pressures on the veins are going to be higher and the water starts to escape. So what happened with the kidney? The kidney is going to have less volume of blood, less blood going to the kidney. And the kidney, in that case, is going to say, all right, so we have low blood pressure on the kidney. So the kidney, what it's going to do is to try to increase the blood pressure. And how we are going to do that? The kidney is going to release the renin, activating the RAS system, the renin-angiotensin-aldosterone system, the renin. So this is another component. And what we can control that decreasing the renin, at least carine that we was talking in the past. They are going to suppress the production of renin. All right. Okay. Now, the ejection fraction. The ejection fraction are going to be the fraction of blood that normally your heart is going to pump out. For example, you have here the ventricles. This is the ventricles and this is the atriums. They're coming about 100 to 120 mLs of blood. So it's like a half of a cup of coffee that is coming, is actually fill the ventricle. Could be the right or the left. So 120 mLs. From these, they are going to eject about 80 to 90 mLs. So that is what is coming out. There is a remnant of blood, normally happen this, that is going to be between 40 to 30 mLs that is going to stay in the heart. That is about. So that is normal. So that is, if you divide the amount of blood coming out and the amount of blood that stay, that is called the ejection fraction. The ejection fraction means that you eliminate about 55 to 70% of the volume of blood in the ventricle. The rest is going to be ejected in the next cycle. But at the same time, the blood is keep coming from the left atrium. Keep coming. And what is the next cycle is going to eject about 55 to 70%. 55 and 70% of the blood from the heart. That is normal. Now, the ultimate thing is when you have a patient with heart failure, they are going to enter into what we call the echocardium. In the echocardio, that is an ultrasound of the heart, they can measure how much volume of blood is coming out from the heart. In other words, in an echocardio, they are going to measure the ejection fraction. What is the amount of ejection fraction normally happen? Between 55 to 70% out. So that means 45 or 30% are going to stay in the heart and is going to be ejected in the next cycle. So that is important. So when you have a patient with heart failure, you're going to do the monitor of the patient, but the patient treatment are going to be variable according what they are going to find in the echocardium. If we have less than 40 or 45 or less than 40, and even lower than that, the treatments are going to be different, similar but different and more aggressive. So there's, in this class, what we are going to do, focusing on Engels and Hesse, they don't want you to know what is the treatment for this and that in that situation. What they want to know are actually the drugs that are going to be used in heart failure. And that is what we are going to do right now. Okay? All right, so signs and symptoms, you know the cardinal signs of heart failure. So I put here, you already know, please, you need to link your class with your clinicals. All right, so you need to remember that actually we have the way to auscultate the heart. So that is part of your physical exam. Alexa, stop. All right, so that is the, I put in this slide in order you to remember a few things. S1 is going to be the systolic, means the contraction of the heart, and that produces the S1 is the sound of the closure of the tricuspid and mitral valve. S2 is going to be S2 is the closure of the semilunar valves. Is what we call DOP. LOP with L is S1, closure of the mitral and tricuspid. And LOP, DOP with D is the closure of the semilunar valves, the aortic valve and the pulmonic valve. LOP, DOP, LOP, DOP, LOP, DOP, LOP, DOP, LOP, DOP, LOP, DOP. All right. So let's go to the treatment. All right. The treatment, okay, nursing diagnosis, that is part of your med search. I'm not going to go on that at this moment, but let's make something here. Decrease cardiac output. Okay, so there is a problem with the treatment of heart failure. You can decrease too low the cardiac output. So they need to keep it in certain range. How you can check the cardiac output? What is your nursing diagnosis? How you can, after you do your assessment, you're going to do the nursing diagnosis. And one of the nursing diagnoses will be the decrease of cardiac output. So what you need to remember here? The decrease of cardiac output you measure with the urine output, the urine of volume that you urinate in a day. So you need to urinate about 1 ml per kilogram per hour. Per hour, yes. Per day, sorry. Minimum per day. More than 1 ml per kilogram. Or if you need to urinate less than 30 mLs per hour. If you have less than this volume, that means that the kidney is not filtrating. If the kidney is not filtrating, it's because you have too low blood pressure, and the kidney can enter into kidney failure. That is one of the complications of the heart failure. All right, decreased cardiac output. All right, activity intolerance. So the patient cannot walk because the heart is not pumping properly, it's not oxygenating properly. Excess of fluid volume, heart failure, heart on fluids. Heart failure, heart on fluids. Impaired gas exchange. Impaired gas exchange, where is the gas exchange? In the alveoli. Why? Because if you can have right heart failure, and that is going to produce pulmonary edema, and that can decrease the gas exchange. Now, listen to this. Heart failure, we call these two congestive heart failure. You can use both ways, but when you're using congestive heart failure, it means that the patient is basically decompensated. So that means there's accumulation of fluids in the body. But heart failure and congestive heart failure basically refers to the same thing. Impaired skin integrity. Why? because the patient is in a position that is not moving, is resting all the time, sitting. He doesn't want to walk because he's having dyspnea. And that can produce ulcers on the skin. And knowledge deficit. This is a lot. So if you can tell all what you need to explain to the patient is a lot. So most likely this is a very common situation that the patient doesn't know what to do. And it's a very common diagnosis, the knowledge deficit of knowledge, okay? The goals for the heart failure are going to be decrease the signs and symptoms. What are decrease the signs and symptoms? Are going to be the dyspnea, right? SOB, decreasing, for example, the edemas in the body. Increase exercise tolerance. If you control your blood pressure accordingly, in heart failure, you can still having some activity. So walking to the bathroom, go to the table to eat your breakfast, or something like that. So increase exercise tolerance, prolong the life. Treatment is to correct the underlying disease. So that is basically the problems that can cause heart failure. Coronary artery disease, right? CAT are going to be blockage, for example, right? They can lead into myocardial infarction that can produce even worsening the heart failure. Hypertension, there you are, hypertension. Hypertension, at the end, what is going to do is accumulation of fluids, not only in the abdomen, in the lower extremities, but in the lungs, and that can produce dyspnea. Dyslipidemia, always you need to have the patient control his cholesterol levels. Thyroid disease, especially the hyperthyroidism. In the hyperthyroidism, you have tachycardia, your blood pressure go up. In hyperthyroidism, vital signs are going up. In hypothyroidism, vital signs go down, right? So in hyperthyroidism, your temperature go up, your blood pressure go up, your heart rate go up, your respiratory rate go up. So all these we need to correct. So if there is underlying or another precondition of the patient that need to be resolved in order to control the heart failure. Bed rest when is necessary. Sodium restrict diet. Why sodium restrict diet? Sodium restrict diet means that if you eat more sodium, more salty food, you're going to retain more water. And the problem with the heart failure is that it's hard on fluids. You don't want to retain that much fluid. So that's why you restrict your sodium. Is that clear?
Yes.
Okay. All right, so treatment of emergency settings, we have the ACE inhibitors. The ACE inhibitors is the angiotensin convertase enzyme inhibitor, is going to decrease the production of aldosterone. All right, so we have the dobutamine. Dobutamine is going to produce actually vasodilation. Dobutamine produces vasodilation. It's another medication we are going to talk in a few moments. Nitrates are potent vasodilators, arteries and veins, and oxygen. Oxygen is needed when the oxygen saturation, oxat, is less than 90%. If the patient is having 95, 98, you don't need oxygen. So this is under the condition of the saturation of oxygen, oxat, the oximetry is telling you that you have less than 90% saturation of oxygen. That is the moment that you are going to use oxygen, okay? Morphine. Morphine is only when you have severe pain. Severe pain is when you have 7, 8, 9, and 10. Anticoagulants. Anticoagulants are going to be, we are going to talk about today about that. Anticoagulants, why? Because the blood, when is in heart failure, is getting slow. And when you when you get a slow flow of the blood, there is a risk of clotting process. So that's why they are going to use a dual full anticoagulant and blood thinners that we are going to see, that antiplatelets like NSAIDs and antiplatelet aggregation. We are going to see that today. All right, treat them after. So after the patient is compensated, they go home. They are going to use the ACE inhibitors. They are going to be the B blockers. They are going to be the diuretics and the digoxin that we are going to talk in a few moments. Digoxin, very important. All right, so that is what you need to memorize for the exam. ACE inhibitors, you already know. ACE inhibitor, the side effects, we was talking in the heart failure, in the heart hypertension, etc. Right? Hyperkalemia, be careful with the hyperkalemia. Don't give it with aspirin. Diuretics, what is doing this? The ACE inhibitors is to decrease basically the ACE inhibitors, angiotensin decrease the aldosterone at the end and decrease the sodium absorption, decreasing the preload, decreasing the preload of the heart, so the venous return of the heart. Diuretics is going to be directly of the preload reduction of the volume. So the stroke volume is going to decreasing the blood pressure, right? So we want to decrease the blood pressure, but not that low, because they can produce problems with the kidneys and brain. Vasodilators, we have the nitrates. We have the hydralazine, that is very good medication because it's very fast, we can control that half-life time is very short, so it's under control. So hydralazine is used in clinical facility, hospital, not at home. Nitrates is the one who is used at home. Prazosin, that is actually an alpha-1 antagonist or blocker that produce that vasodilation. So we have vasodilation, diuretics, ACE inhibitors. So that is the ACE inhibitors side effects. We already talked about that. All right, so we have beta blockers. They can be used beta blockers. We have the bisoprolol, the metoprolol, the carbidol. So tell me, these drugs are selective or not selective?
Selective.
They are selective. You remember, I will tell you, for those who didn't come to previous, is that in the beta blockers, besides that we was talking before, if you have the word start with A, B, C, D until N, all the word nadolol, atenolol, bisoprolol, metoprolol, carbidol, all that are between A and N are going to be beta blocker, selective beta blocker. And wherever is O, P until the C, that is going to be no selective. You okay with that?
Yes.
Okay, excellent. All right, so let's talk about digoxin. All right, so and we finish this? Yes. We finish heart failure. Okay, perfect. All right, so let's talk about the digoxin. And for that, I need to give you some. All right, so what I'm doing? No. I like black. What are my glasses? That's why I cannot see. All right, so digoxin is very important medication. So this is very high yield for the exam. It's going to be 30 questions next class and not 25 because I'm going to include 5 or 6 questions for heart failure. Okay. Come on. Okay. All right, so let's talk about the digoxin. Digoxin is, the other name is glucoside. Or called digital. And the commercial name is the lanoxin. This is always coming, okay, registered, that means R. All right, so lanoxin is the commercial name. All right, so this digoxin is going to be two things. It's going to be chronotropic, negative, and is going to be inotropic, positive. Chronotropic negative means that the heart rate is going down. And inotropic positive means that the afterload increase. Remember, afterload means contraction of the force of contraction. Afterload doesn't mean volume. But that depends on the volume that is coming into the ventricle. The more volume, the more distension, rubber band is going to contract harder. So, but afterload definition is just the force of contraction. Afterload. Okay? Force, F, force of contraction. All right. So that is the chronotropic and inotropic. Chronotropic negative and inotropic positive. So what they are doing is this. Digoxin is being used for two things. They can be used for arrhythmias, because if your heart is doing boom, 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 digoxin is going to decrease the heart rate. It's going to be now boom, 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 normal rate. Inotropic. Digoxin we are going to use in heart failure, mostly on the last stages. When the heart is ready to give up. The heart is ready to give up. It's going to give up. So that is the moment that they are going to start using digoxin. And digoxin are going to do is inotropic positive, is going to help to contract harder the heart. There is no other option. Otherwise, if we don't give the medication, cardiac arrest, the patient dies, right? So digoxin is one of the latest medications that we use in advanced stages of heart failure. Okay, the only solution of heart failure at the end is heart transplant, right? Okay, so saying that, this is important, so please. I told you, okay, so here we have the myocardial cell. This is the myocardial cell with striations and intercalated disc, whatever, right? So, and here we have digoxin. I'm going to put digoxin like a dot, like a red dot here. I'm going to put digoxin, 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 digoxin. These digoxin are going to use a receptor. They're going to use a receptor. This receptor need to match with a digoxin. So let's make a digoxin is like this, like a triangle. Like a triangle. So this triangle are able to match the receptor. And that is how digoxin is going to get into the cell. You okay with that?
Yes.
All right. Second, what we are going to end here, apical pulse. Yeah, we are going to end in the apical pulse. Listen to this. Now, but what happened? We have potassium. In the other hand, potassium, 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 potassium. And these potassium are going to use the same receptors of the digoxin. So this potassium use this receptor as well. This potassium use this receptor as well. This potassium are going to use this receptor as well. So what does it mean? That there is between the potassium and digoxin, there is a competition. They compete for the same receptors. You follow me?
Yes.
Okay. So now, so you're competing for the same receptor. Now, what happened? What happened if I have no potassium in my blood? No potassium. I don't have no potassium. There is no potassium. Tell me, if there is no potassium, digoxin is going to compete with somebody? The answer is no, right? If there is no competition because you have low levels of potassium, what can happen? Digoxin is going to enter in huge quantities into the cell, leading in toxic levels. What is the problem with the toxic levels? That if you have too much digoxin into the cell, what is going to happen is a chronotropic negative. And what you're going to end into cardiac arrest. You okay with that?
Yes.
So what do you need to control in the laboratory test? What do you need to check before you give digoxin? Which laboratory test? Which laboratory test you will need to know in order to give digoxin to the patient?
Potassium levels?
Potassium levels. What is the normal values of potassium?
3.5 to 5.
3.5 to 5. So if your laboratory test is telling you that you have 3.0, do you give digoxin?
No.
No. Why? Because if you have low potassium, there is no competition with digoxin. So digoxin do whatever they want. So they get in more quantity into the cell, increasing the risk for cardiac arrest. Why? Because the more digoxin you have, the more decrease your heart rate. So one of the considerations that you need to look for is this, is that you need to check the apical pulse. Apical pulse. The apical pulse is telling you that you have less than 60. Less than 60, you need to observe the medication. Some patients, they say between 59, 55 and 59, that is the goal for that. But below 60 for Enkles and Hesi, you need to stop the medication. So you need to be aware of that, because if you have hypokalemia, and you need digoxin, the patient are going to have actually bradycardia and produce cardiac arrest. So you need to code the patient. Is that clear or not?
Yes.
All right. All right. So always take the apical pulse for 1 full minute, as you know, before administration. Do not administer when the heart rate is less than 60. That is Enkles. The therapeutic range. What is therapeutic serum digoxin? What do you understand serum digoxin? What do you understand with that? Serum digoxin. What do you understand with that?
Digoxin in blood.
Yes, the concentration of digoxin in blood. Serum means blood, laboratory test. Serum calcium, serum potassium, serum sodium, whatever you want, serum albumin, serum myoglobin, serum whatever. Serum means a laboratory test that checking the concentration of what you mentioned in the blood. Okay, in this case, serum digoxin is going to be 0.5 to 2 nanograms. Nanograms, no milligrams, right? Nanograms. If you give milligram, you're going to give 1,000 times more. The patient is just goodbye, right? So how to remember that? Digoxin N is nano, N nanograms. N. You okay with that? N and N. You okay?
Yes.
And the values is 0.5 to 2. That is the normal range that should be digoxin in blood. Okay? So one of the first, and that is high yield for NCLEX. Digoxin toxicity, they're going, I should put here in color. Put it yourself, please. Anorexia and nauseous. That is the earliest anorexia and nauseous. Of course, if you're nauseous, oh, I'm nauseous, I want to eat. So who's doing that? Nobody. If you're nauseous, you don't want to eat, right? Yes or no? Right?
Mm-hmm.
So if you're nauseous, you want to vomit, you don't want to eat. So anorexia, nauseous. One of the first time. Then you're going to go to the eyes, visual disturbances. So this is, I put it in yellow because you see yellow, so you see halo. So look at a bulb light, and around the light you see like a halo. This halo is going to be yellow or green. Oh, nice, yellow or green. No, you have toxic levels of digoxin. What are you talking about, right? So that halo around the lights are going to be yellow or green. So that is digoxin toxicity. So you need to stop the medication, laboratory test, call the healthcare provider. Okay? You need to check the digoxin levels immediately. Go to S-bar, and the S-bar go to the actually call the doctor, whatever you needed, that you need to order a laboratory test for toxic levels of digoxin. Early signs of, include anorexia, nausea, vomiting, and bradycardia. Okay. All right, so cardiac fault, yeah, so that is going to be another time. So that is what you see in the search mature. All right, oh, this one, the antidote. The antidote is the Digiband, the Digiband. That is a must you need to remember, the Digiband. Okay, Digiband. All right, so Digiband. All right, so we okay with that?
Yes.
Okay, so that is what I want. So in conclusion, what I want you to remember is that we are going to use furosemide to decrease the retention of fluids. We are going to use beta blockers, especially the selective one, and they can be mixed with ACE inhibitors or with ARBs. Then you can use the spironolactone, because, all right, so in order, if you are using digoxin, you're going to basically try to not lower the potassium. And spironolactone is a potassium sparing. Digoxin. So basically, that is the treatment for the for heart failure. All right. So in summary, that's all what you need for your NCLEX and GESI. Details and all that, it can be probably another time. But yes, remember, furosemide, beta blockers, and the beta blockers need to be associated with beta blockers plus ACE inhibitors or beta blockers plus ARBs. You can use a spironolactone if you're using digoxin. Why? Because it's potassium sparing. So basically that. You okay with that?
Yes.
Yes.
Okay, so that's it. So let's go to our lecture today. I'm going to give you 10 minutes break. Anna, how was the heart failure? Is clear? So?
It is a lot of information, but I think it all ties back to last week's lecture. So I think if I get that stuff down, I think this will make more sense.
So doesn't make that right now, it's not making that much sense?
No, it makes sense, but I feel like it all ties down together.
Okay. Who want to go directly to the jugular? Dancing jugular. Okay, let me see who likes to dancing jugular. Oh, there's Charlize. Where is Charlize? Oh, Charlize, there you go. Yes, Charlize. Go. Go directly to the jugular. Anything that you don't like it, anything that you can change, want to change, repeat, clarify, change instructor, change something.
No, I understood how you explained it, Dr. J.
Okay. Adriana, you can tell me a little bit more panoramic view. So tell me, what do you think? Is clear or not?
I think it
What
was
I can
clear.
improve? Huh?
I'm sorry, what was that?
What can I improve in your point of view?
Um, I mean, at least for me, I'm a learner who's just I need a lot of repetitive. So I think the recording helps going back on YouTube. Will definitely make things stick. But so far I think it's pretty good. Thank you.
Okay. All right. Okay. Anybody want to make a comment? Thank you so much, Adriana. All right. So I'm going to give you your break. Okay. So I'm going to give you until 12:42, 10 minutes. Okay. 10:42.
Thank you, Dr.
All
J.
right. Sure. It's time? At what time we said? 48? At what time we said we are coming back, Gerald?
Now.
Now? Oh, okay. All right, so let's start. All right, so we will talk about antiarrhythmics and anticoagulants. Okay. So for this, let's talk about these arrhythmias. Tell me, help me with that. You did arrhythmias in med-surg already?
No.
We talked about it a little bit.
Like what? What is in our mind about arrhythmias? What is the concept you have arrhythmias? What is an arrhythmia?
Irregular heartbeat.
Irregular heartbeat. What is the normal heart rate? Everybody.
60 to 100.
60, 100, right? 60 to up to 100. So up to 100, more than 100 is arrhythmia? I'm trying to make clear the concept. Yes and yes, no, in order to keep going. More than 100 is arrhythmia already or no?
Yes.
Yes. But less than 60 is arrhythmia?
Yes.
Yes. What means arrhythmia? Arrhythmia means out of the normal rhythm. So everything that is going to be higher than 100 or high or lower than 60, those are arrhythmias. Those are going to be called tachycardia, more than 100, and bradycardia, less than 60. Now, the arrhythmias, when is more than 100, could be like this. Look at this. Listen to this. I will say, okay, I will try to make sound. Pum 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 pum. That is arrhythmia. That arrhythmia is, if you see here, that arrhythmia is rhythmic. Yes or no? It's a rhythmic arrhythmia. Yes or no? Because it's going to be the same. Pum 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 pum. Right? But if I have like this, pum 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 pum. My cats are coming. Boom, 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 boom. So that is an arrhythmia too, but it's an arrhythmic arrhythmia. We okay with that?
Yes.
Okay. So we have rhythmic arrhythmias and we have arrhythmic arrhythmias. In general, we call these arrhythmias. It's the same. Are the same. Now, just to go directly to the point, because I've been preparing you from anatomy, physiology, and bioscience, so you will see why I say that. So that's why it's going to be very nice and short. Is that talking about drugs that we are going to learn today, and these drugs are going to have side effects. What could be the side effect of the antiarrhythmic medications? What do you think? Okay, let's focus on the tachycardias, arrhythmias, right? So if you have pum 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 pum, and you give antiarrhythmic, what is supposed to happen?
Slow it down back to the normal range.
Exactly. But if you give too much of this antiarrhythmic, what happens?
It'll slow down too much.
Exactly. And that's getting into arrhythmia, or no?
Yeah.
So as a conclusion, listen to this. Antiarrhythmics are the side effect, the most common side effect are going to be arrhythmias. Make sense?
Yes.
Yes.
Talking about the side effects, okay? Side effects, okay. All right, so let's go directly to the classification of the arrhythmias. And that is what you need to keep in mind. So basically today we will mostly talk about tachycardias, arrhythmias, all right? So you can tell arrhythmias, bradycardias. So arrhythmias divide in bradycardias and tachycardias. All right, so the tachycardias, you need to know this classification very well. The tachycardias can be basically, you remember the electrical circuit or the nodal circuit of the heart activity. You remember that we have the SA node. The SA node is located in the atrium, right atrium. All right, so let's see if I have a picture of that. Okay, there you are. Okay, so here we have, these are the circuits that are making the heart contract. This one that is, as you see in the right atrium, is the sinusal node, or called the SA node. This SA node is the sinoatrial atrium node, or called the pacemaker. It's not the pacemaker, it's the pacemaker. Pacemaker. We okay with that? This is going to depolarize, means sending electrical impulses between 60 to 100. So that is the commander, basically. That is the one who commands your heart rate. So you have a sinus rhythm. Sinus rhythm is what you write down in your physical exam and clinical history. So sinus rhythm. So that means that is between 60 to 100. Now what happened? This is going to go the electricity are going to be spread out. It's like you put water on the floor. So put a glass of water and put it on drain it on the floor. So what happened is the water is going to be wet close to you. The water is going to wet the floor close to you, and then they're going to keep going forward. Yes or no? Right? Yes or no?
Yes.
Yeah. So what happened with is the same with electricity. Electricity are going to start spreading out like this. First here, then here, then here, then here, then here, then here, then here, and then here. And then again, they are going to start another electrical impulse here, spreading out in this manner. So that means that first of all, the first contraction are going to happen is in the atriums. Then after the atrial contraction are going to happen the ventricular contraction after the atrial contraction. Okay? All right. So now here we have this SA node that depolarized 60 to 100 bits per minute. They are going to go and find out another node, that is the atrioventricular node. Why is called atrioventricular node? Because it's between the atriums and the ventricles here, the atrioventricular node. So they are going to basically going to go from they're going to go from 40 to about 59. So let's make it like this. It's going to be 20 to 55. So they're going to produce depolarizations. But you say it's confusing. Why? Because if I have 60 and this 20 to 59, so why is that? Why we have two of these? All right, so what happened is this. So when you right now, you have the SA node working properly, your SA node is working nicely, it's beating 60 to 100. So when this is normal and working okay, very nice, this atrioventricular node keeps silence. They are going to just allow they are going to pass the electrical impulse. So this is not working. So it's just allowing the passage of the electrical impulse. Then we have here, they are going to transport by a bundle that we call the bundle of His, or as a bundle of His bundle, the His bundle. This is not going to depolarize. What they are doing is just to allow the passage of the electrical impulse. Then they are going to reach what we call the Purkinje cells. Purkinje. I'm going to write it down. Purkinje. The Purkinje cells are going to depolarize between 20. No, this is, sorry, I need to make a mistake. It's going to be 40 to 59, and this is going to be 20 to 39. So very low. So these are going to depolarize or make contraction in about this number. Okay? All right, so what these Purkinje are depolarized very slow. So that means that when this is working normally, the SA node, the Purkinje cells are going to be keep silence. So they are going to allow just the transmission of the electrical impulse. So how we can explain that now? When you have a heart attack, or a myocardial infarction, if the SA node is destroyed, if this is destroyed, the SA node, the one who is going to take care of the cardiac activity are going to be the atrioventricular node. Just only in that case. When the SA node is not working, your AV node is called the AV node because atrioventricular node are going to basically start to be working. Okay? So if you have a massive myocardial infarction, this is going to be destroyed. This is going to be destroyed. So who is going to take over are going to be the Purkinje cells. That is going to depolarize, make contraction between 20 to 40. Is that clear? We okay with that?
Yes.
Thank you. And when you see the movies or something, they say that the monitor is going to be like first of all, are going to be at the end of the age of life, the patient is having a massive myocardial infarction. So you see the beeps of the monitor in the movies. They say beep, 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 beep. And supposed to be beep, beep, beep. So that means that there is all this is are being destroyed, and the only one at the end that is actually surviving are the Purkinje. But this rhythm is incompatible with life. So the patient suddenly is going to enter into beep. That's it. You okay with that?
Yes.
All right. So now, in order to understand these arrhythmias, that's why I need to, first of all, I had to explain this first. We have what we call ectopic nodes, reentries, ectopic nodes, etc. These ectopic nodes, ectopic means, what means ectopic? Ectopic. It means out of place. So we have extra nodes. Instead to have this node here, we have a node here. We have areas that are going to depolarize spontaneously. It can happen here on the atriums or can happen here on the ventricles. And these, in addition to the SA node depolarization, they are going to depolarize to these nodes, extra nodes. So the extra nodes that are going to depolarize spontaneously as well. And those nodes are going to be called ectopic nodes. So there is so much information that the heart starts to beat faster. It's like boom, 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 boom. And that is the cause of arrhythmias. One of the causes of arrhythmia. We okay with that?
Yes.
Now, let's go to the classification. Now, tachycardias that we just mentioned, we are going to divide the nodes, extra nodes are going to be located in the supraventricular area. Supra means above. Means above. We don't call atrial, all right? So we call supra. Supra means that all nodes that we are talking about are located, could be 1, 2, 3, 4, whatever, are going to be located in the atriums, that is above the ventricle. So that's why we call supraventricular arrhythmias or supraventricular tachycardias. Okay? And now, if the nodes are located here in the ventricles, any place could be 1, 2, 3, or more, are going to be basically ventricular arrhythmias. So we have the classification of arrhythmias will be the supraventricular, above the ventricles, and the ventricular. You okay with that?
Yes.
Simple, excellent. Now, here we have the supraventricular arrhythmias, and the supraventricular arrhythmias are going to be the atrial, because the supra, right? Atrium. Atrial fibrillation is called the AFib, and the atrial flutter. So we have two things, fibrillation and flutter. Fibrillation and flutter. Fibrillation is going to be this. Fibrillation are going to happen when you have a myocardial infarction. There is a shortcut or wiring there, and instead the atrium doing this, the atrium now is doing this. Can you see my hands? That is fibrillation. So basically, it's not an effective contraction. So instead to do this, now the ventricles literally are doing this. Okay?
Yes.
Now, here we have the atrial flutter. Atrial flutter is going to be, the normal is going to be like this. But now in flutter, it's going to reach like 300 or more. So that is effective contraction, but very fast, the atrial flutter. So you already know tachycardias are divided in the supraventricular, supraventricular and ventricular. Supraventricular, think about the atriums. What type of arrhythmias we have? The atrial or the AFib fibrillation, the atrial fibrillation, and the atrial flutter. The Wolff-Parkinson-White, we are going to talk about very brief. That is basically med-search, but it's basically a re-entry. It's like a re-entry, like a circle, one again and again. So I'm not going to talk about that now. So let's make it simple, because my goal here is actually the drugs right now. And the ventricular. We have ventricular arrhythmias or tachycardias. Ventricular because the ectopic nodes, the extra nodes, are located in the ventricles, making a depolarization, electrical impulses that make the heart contract faster. And again, we have very simple, ventricular fibrillation, and the ventricular flutter. Ventricular flutter. The ventricular fibrillation is going to be the ventricle, instead to contract like this, are going to contract like that. Atrial fibrillation. You okay with that?
Yes.
Okay. And the ventricular flutter is the killer. It's very, very hard to control. So ventricular flutter is going to be 300 beats per minute. So it's a lot. Okay. So yes, you can tell you have the mind map already. Your mind map is tachycardia or arrhythmias are going to divide in arrhythmias coming from the atriums, that is called the supraventricular, and divided into fibrillation and flutter. And the ventricular arrhythmias, because the ectopic nodes are in the ventricles, are going to be ventricular fibrillation and ventricular flutter. So that is the four type of arrhythmias that you mostly will find. Okay? Is that clear?
Yeah.
When somebody have a myocardial infarction, okay, they can lead into what is the worst, is the cardiac arrest. Cardiac arrest. When you have cardiac arrest, you need to do a CPR. You're not going to do defibrillation. The defibrillation are going to be to take out from the fibrillation. If the heart is stopped and doesn't have any activity, you can put 100 times a defibrillator, shock the patient, and nothing is going to happen. They need to have some cardiac activity and you see the ventricular fibrillation is going to be like waves very fast. And that is the moment you're applying the defibrillation. You cannot apply defibrillation when the heart is totally stopped. So when you are doing the CPR, you are trying to activate the heart again to pump blood, oxygen to the body until the heart actually get into reactivation and produce the shortcut, the fibrillation, ventricular fibrillation. That is the moment that we call and we do the defibrillator, the shock, 150, 200, 300, 300 volts, millivolts. So that is what we are going to do, volts. Okay? You okay with that?
Yes.
All right. So now, this is something that you're familiar with. Okay? So there is some variations, but we are going to go that. So just remember, this is the cardiac muscle. That is inside what happened in the cardiac muscle, right? And what you see here is that this portion is going up to here is going to be the contraction of the muscle, contraction of the heart, and that is the relaxation that we talked in the past, right? If you see here, the first thing that is going to enter is the sodium. Then, in order to complete the contraction, is going to be calcium. In the muscle, striate muscle, smooth muscle, the curve is something like this. In the nervous system, the curve is going to be like this, very spike. And the heart, the curve is going to be like this. So that's why I draw it in one time. So we don't need to know what is the difference between this and that. So it's just what the contraction happened. So we need to know that sodium enter to complete the contraction is going to be calcium. And in order to do the relaxation, potassium, chloride, and magnesium going out. But in this case, we are going to focus in the potassium only. So we have sodium, calcium, potassium. Sodium, calcium, potassium. You okay with that?
Yes.
All right. So knowing that, we are going to do the classification of the of Vaughan-Williams. That is, they like to ask you in med search, by the way. Okay. What is the classification name for this supra and ventricular are going to be the Vaughan. How you pronounce Vaughan-Williams? Okay. All right. So here we have just general scenes, atrial fibrillation, basically happening in patients who has a myocardial infarction. So the atrial fibrillation is very common to see in patients with a myocardial infarction. There is a part of the circuit that is dead, and basically the atrium responds with re-entries and produce this fibrillation of the atrium. Now, can you see the fibrillation in between? This is the fibrillation. Can you see the blood moving between my fingers? Can you see that? Use your imagination, please. Please, my God. What happened with you guys today? Only one is answering all yes, no. This is boring for you? Tell me.
No.
I want you.
No, Doc.
So please, just tell me, it sounds, whatever, just to let me know that you are there. It's very hard for me, for anybody to teach and nobody here. So I don't know if so I cannot tell. All right. So if you see here the atrium fibrillation, so I don't know if I can do more or less. So that's why you need to help me on that. If the atrium is fibrillating like this, otherwise I can basically just don't care and keep talking without repeating. So please. All right, so we have here the atrium, the fibrillation, the blood is moving between my fingers, but what is in the center of the cavity, the blood basically is not moving because they have different forces coming from right to left, up and down, etc. And basically the blood is not moving in the center of the cavity. That actually can lead into not moving of the blood. Remember the Birchoff triad? We talk about the Birchoff triad, right? Remember the Birchoff triad? Okay.
I
So
don't remember.
okay. Tell me, the Birchoff triad, Birchoff triad is very important. The Birchoff triad means three. So there's three causes that can produce clots. Three causes that produce clot. One cause is the stasis. So it's when the blood is not moving. The blood not moving. Second is when you have increased thickness. Thick. The blood is very thick. It's called the viscosity. Viscosity with C, I guess. Okay. Sorry, I need to. How you spell viscosity? Viscosity. Like this? Yes, viscosity. Yeah. It's viscosity. So it gets thicker. If the blood gets thicker, because, for example, you are dehydrated, you're losing the water by the solutes, the red blood cells, the platelets have the same number, so the blood becomes more thicker. And that can produce a slowdown of the flow. Slowing down the flow, they can produce clot. Example, you pinch your finger with a needle and the blood is coming out. But the blood, when it's like a small balloon in your finger, is not moving. And in a few seconds, the blood starts to clot. That is a proof that the blood, when it's not moving or slow down the movement, can actually increase the risk for the formation of a clot. Okay? And number three is endothelial damage. That actually, I'm not going to explain that because it's taking me 10 minutes. But nevertheless, okay, let's do it. So we have the endothelial damage, we have endothelium, we have smoking, we have free radicals, whatever. They are going to basically damage the endothelium. This endothelium, the tunica intima of the vessel, are going to repair. So they are going to form a scar. A scar. If you have a scar here, the blood that is coming here are going to pass the scar, and they are going to have a turmoil here after the obstruction, after the clot, after the scar. And that means the blood is coming, go and back, go and back, go and back, go and back. And that basically what is doing, decrease the velocity of flow of the blood. And that can produce a clot again. So in this case, what I'm talking about atrial fibrillation is a stasis. So when the blood is not moving, and pinch your finger and wait until you stop bleeding, you're not going to bleed until you die, right? It's going to be bleeding just a small time. Why? Because the blood is not moving, and that promotes the clotting. It's the time where the platelets and the fibrin are going to be working on that moment when the blood is not moving. All right, so atrial fibrillation. So when you have a heart attack, you have patients. Do you notice a patient who has a myocardial infarction? And after they been resolved the myocardial infarction, after 2-3 weeks, 4 weeks is the statistics, that are higher number of strokes. Yes or no? Do you notice that?
Yes.
Yes.
So if you see many people, you see, just asking the patient. So the patient is having a stroke, and the patient is telling the history. Previously, he had a myocardial infarction. Right? All right. So after the myocardial infarction, they have the atrial fibrillation was not treated properly to prevent the clotting. So you need to give aspirin, anticoagulants. If that is not working, it's going to create a clot. If the clot is on the left atrium, because it's atrial fibrillation, it can happen in the left or in the right. If they happen in the left atrium, the clot go to the left ventricle. From the left ventricle, go to the aorta. From the aorta, the clot can go to the carotid artery, to the brain. And the clot is going to match the diameter of the vessel, blocking the transportation of blood. And that area of the brain is the cerebral infarction. And that is called a stroke. If the clot happened on the right atrium, the right atrium, the clot is having atrial fibrillation on the right atrium, the clot is going to travel to the right ventricle. They go to the pulmonary artery and they go to the lungs. In the lungs are going to, the arteries are going to be this side, and there is a moment that the clot is going to match the diameter of one of the vessels, blocking the transportation of blood and oxygen to the lung tissue. And that is called pulmonary embolism. Pulmonary embolism. Okay, we got it?
Yes.
Yes.
Okay, so let's get started with the names. So here we have the classification of the antiarrhythmics. We have, just remember, class 1, class 2, class 3, class 4, and class 5. Okay? 1, 2, 3, 4, 5. Okay? How to remember that? Remember the schedule 1, 2, 3, 5. Yes, whatever you use, all your tools. So we have 5 types of antiarrhythmics. We okay with that?
Yes.
Okay. The first class of antiarrhythmics are going to be the sodium channels. Oh, okay. So if you remember the sodium, calcium, potassium, chloride, magnesium, right? So in order to produce that contraction, you need to have the entry of sodium first. So what happened with these arrhythmias? There is a lot of sodium getting into the cell. So a lot of sodium are going to produce more depolarizations faster. And what about if we block those channels partially? If we block those channels, they are going to basically decrease the depolarization of the nerve cell, and that is the first class, is the sodium channels. So block the sodium channels, blocking the sodium channels. Be okay with that?
Yes.
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 Okay. All right. So now we have here the class 2. The class 2 is going to be the beta blocker. How to remember that? The class 2 is beta, the second letter of the alphabet, beta blockers. Beta blockers. So what is doing? The beta 1 is going to increase the heart rate, but the beta blocker are going to decrease the heart rate. That's why we use beta blockers. So it's the class 2. Class 2. You okay with that?
Yes.
The class 3, and that was in the order that was being discovered or produced. So that's why they have this number 1, 2, 3, 4. The class 3 is going to affect the efflux of the potassium. So the potassium is supposed to go out. But if we stop the potassium getting out and stay inside, the repolarization means the relaxation is going to last longer. If that relaxation or repolarization lasts longer, the next contraction is taking more time to happen. Make sense or no?
Yes.
Okay. Potassium. How to remember potassium? Very simple. Potassium. 1, 2, and 3. 1, 2, and 3. 1, 2, and 3. 1, 2, and 3. Just to write the potassium. So that means class 3. All right. Class 4, you need to remember this. Class 4 is the calcium. Class 4 is the calcium. So how you can remember? I don't know. Probably this 1, 2, 3, and 4. Calcium is calcium plus, right? How many letters we have, or how many symbols, etc.? 1, 2, 3, and 4. Calcium we have is class 4. Class 4. And class 5 will be the digoxin. Digoxin is one of these drugs. All right. So tell me, what is class 1? Tell me the mineral that is we are blocking. Class 1, sodium. Class 2,
Sodium. Potassium.
Class 2,
Beta blockers.
Beta blocker.
beta blocker. Class 3,
Potassium.
Potassium.
awesome. Class 4,
Calcium.
Calcium.
and the class 5, there could be the digoxin. All right. So let's get started. Nursing considerations. Let me see. All right. So, okay, we are getting there. Assess cardiac rhythm. You need to know how to read the EKG, right? So you already been taught to do EKG. Mr. Verda is having nice activity or EKG. They're going to do it by sure. So you need to know the rhythm, you need to know the axis, you need to know the rhythm, the frequency, the rhythm, etc. So that is how you need to read the EKG. Anyhow, so it's going to take me like 1 hour to do it. So Mr. Verda, I know that he will do it, and everybody's happy with the EKG.
Dr.
So,
T,
yeah. What?
we have
Yes.
different teacher for med surge now.
We what?
We don't have Mr. Verdad anymore.
Really? Why?
We have Miss Sharina.
Oh, okay. So put in your note how to read EKGs. If not, I will talk to Mr. Verdad to make an activity or EKG. Okay?
Okay, thank you.
Yeah, but I need to consult him. I'm not the owner of the course. Okay? Okay, but if we have time in pharmacology, I can do EKG too. I need to start reading one session, 10 minutes, to have a kind of understanding for NCLEX, at least 2 sessions of 2 hours each. So with that, you have all the material for EKGs. Anyhow, so just put it in your mind, please. I'm ready to help on that, okay? Assess cardiac rhythm, vital signs, and oxygen saturation to use as a baseline. Okay, so just remember the oxat need to be below 90 in order to have oxygen. So you're not going to give oxygen because it looks nice or whatever you think. No, oxygen is a prescription. Huh? Oxygen can kill patient. You know that, right? You know that oxygen can kill a patient or no?
Yes.
Yes.
Okay, because of the stimulus of the carbon dioxide, yeah? Right, in the respiratory center in the medulla oblongata. Okay, perfect. All right, so now, if here we have nursing considerations that I want to highlight is the systolic pressure. The systolic pressure variance would be between 5 to 10. When the systolic pressure are going to be higher or lower than plus 10 or minus 10. For example, if you have 140 and start to, if the patient is compensated and the patient start to have more than 150, right? So that is need to be pay your attention, okay? So when the systolic pressure variation is more than 10 millimeters, that could be some basically some changes that need to be adjusted with the medication. All right, so pro-dysrhythmic effect. So that is the technical word that used in NCLEX and HESI. So I told you already that the most common side effect of antiarrhythmics will be more arrhythmias. But in NCLEX, they call it like this. Pro is in pro, right? Pro, that means prone, right? To produce arrhythmias. Pro-dysrhythmic effect. So that means that the antiarrhythmic can produce side effects more arrhythmias. Okay, simple as that. Okay, all right. So here we have some signs of the cardinal signs: chest pain, dyspnea, chest pain. What are you thinking about chest pain? You need to think about what? Angina, right? It's actually coronary artery syndrome. Okay, acute coronary syndrome. Or they can lead into STEMI, no STEMI, because the chest pain can indicate when it's 5 minutes or more a myocardial infarction, and you need to check if there's a STEMI or no STEMI. Okay, edema, dyspnea because of cardiac problems is the pulmonary edema, pulmonary edema, dyspnea, SOB, edema, lower extremities, fatigue, no oxygenation of the heart is not pumping, palpitation, syncope, fainting. There is not enough blood to the brain. All right, so I'm going to go to the drugs now. That is what I want you to remember. So for the classical questions that come in for NCLEX, and I will be honest with you, in NCLEX, in HESI, they do not ask you too many questions about antiarrhythmics. They ask you a few things, as I'm going to mention right now. All right, so I want just you to remember that class 1, 2, 3, 4, and 5 are used for arrhythmias. Don't try to memorize it's used for atrial fibrillation, ventricular fibrillation, ventricular tachycardia, whatever. No, don't go on that. Just remember all these drugs are used for antiarrhythmics, as antiarrhythmic, period. That's it. Okay? All right, so we have class 1. The class 1 is the sodium channel blocker. Sodium channel blocker. All right, so you understand why it's going to decrease the heart rate. And we have class 1A, we have class 1B, and class 1C. So actually what happened is this. The class 1A is the fastest action. The class B is going to be taking few hours to make effect. And type C is going to take about a day or 2 days to make effect. So it's going to basically the time of effect. And in addition to that, the strongest or the most common antiarrhythmic use are actually the class 1A. And that is what I want you to remember. Class 1A. Okay? All right, so we have, what this doing is decrease the SA note, it's obvious. And the names are going to be this. Disopyramide, quinidine, and procainamide. Can you repeat with me, please? Disopyramide.
Disopyramide.
Quinidine.
Quinidine.
Procainamide.
Procainamide.
Faster. Disopyramide, quinidine, procainamide. Disopyramide, quinidine, procainamide. Okay? Now, here we have the side effects. But before that, I want you to remember how to remember these drugs that is very likely they're going to ask you. Disopyramide, quinidine, and procainamide. And for that, you're going to remember this mnemonic. The double quarter pounder cheese. McDonald's. What is better, McDonald's or Burger King? What do you like? My God, today.
McDonald's. In-N-Out.
Okay. So double quarter pounder. So you got it? Double D, disopyramide, quarter, quinidine, pounder, procainamide. You okay with that? Never forget that. All right. So now, these are actually what they like to ask you is they give you signs and symptoms of lupus. Lupus is an autoimmune disorder that affects basically the kidney, all the body, but especially the kidney. So they have rash on the face. Lupus means wolf. When you go exposed to the sunlight, you have rashes on the nose and the cheeks. And somebody said, "Oh, it looked like a wolf." I don't know where's the wolf there, but somebody said, "Okay, it looked like a wolf." Okay, and wolf in Latin means lupus. Lupus means from Latin wolf. Okay, so and they have this rash, and that is going to give this class 1A, the double quarter pounder, disopyramide, quinidine, and procainamide. You okay with that?
Yes.
Yes.
Okay, excellent. All right, so one thing that they like to ask you in addition is specifically about the quinidine. Quinidine is the mother, the father, whatever of the chloroquine, the hydroxychloroquine, famous here for COVID-19 at the beginning. Chloroquine is used for malaria, but that is basically the base, quinidine. This quinidine is going to produce, when these toxic levels are going to produce synchronism, or how you pronounce that? Synchronism, synchronism. That is the toxic levels of quinidine. Please write it down. They like to ask you that very well, very much. So synchronism is toxic levels of quinidine, and that can produce tinnitus. You remember what is tinnitus?
Ringing in the ear.
Yeah. Ringing a ear, yes. That is one ear or two ears, could be one unilateral, bilateral. It could be, and basically this is reversible. So they can lose the hearing, but temporary, right? So synchronism. Don't forget about the quinidine, please, okay? Class 1B is the lidocaine. All right. So lidocaine, you need to be careful with the lidocaine. Lidocaine, when it's mixed with lidocaine, what it's doing is to decrease the heart rate. But lidocaine, when it's coming with epinephrine, lidocaine is coming from epinephrine, coming with epinephrine. When they put epinephrine and lidocaine, it's used to have anesthesia, anesthetize local areas in order to make, for example, stitches, right? They are going to make sutures, and they need to anesthetize the area. So they contain lidocaine plus epinephrine. So, and you need to be careful with that, because if you have a patient with arrhythmia and you need to decrease the heart rate and you give lidocaine plus epinephrine, what is going to happen? The patient is going to get crazy. So it's going to basically enter into cardiac arrest. Because epinephrine, what it's doing is to stimulate even more the cardiac activity, correct? So you need to be careful with that. This lidocaine is basically alone. That is what we use for antiarrhythmics, class 1B, lidocaine. Lidocaine is used as an anesthetic because lidocaine is coming from the word cane, cocaine. Cocaine is the base of that. So it's not addictive, of course, but they are going to be used the property of anesthesia. Okay, so that's why people, and that is English again, people who smell cocaine, they can have septal nose perforation. Why? Because cocaine produces a potent vasoconstriction. These vasoconstriction are going to basically diminish the blood supply to the septum of the nose, and that can produce necrosis and perforation. Okay, just remember, lidocaine is an antiarrhythmic. Okay. Okay, lidocaine actually can have serious side effects, and that is what they like to you remember are seizures. Lidocaine seizures, lidocaine. Lidocaine side effect can cause seizures. All right, so okay. All right, so here, for example, is how you can get confused here. Look at this. These bottles look the same, correct? Now, this lidocaine contain actually what we call xylocaine, contain adrenaline. And that doesn't say anywhere. But here we have lidocaine again, lidocaine HS injection. See, it's the same. But there is a difference here. This is preservative-free. Preservative-free means that doesn't have anything else, just lidocaine. And this one that doesn't make that reference, that contains xylocaine. So it's easy to get confused. Yes, so you need to be careful to read your medications properly. All right. All right, so class C, there are not going to be questions about, mostly I didn't see questions about 1C. Right, so, but 1C is going to take a longer effect and is going to slow even very deeply the cardiac activity. So it's very potent. All right, so class 2. Class 2 is the beta blocker. We have propanolol, esmolol, metoprolol, and all these guys, it can be selective or not selective, right? So, and you can tell here, do not use in COPD. Do not use in COPD. Why? You know already why, correct?
Yes.
Excellent. Class 3 is from the class 3, the potassium channel blocker is the class 3. Is the one I want you to remember is the amiodarone. Amiodarone. Okay, amiodarone. The amiodarone are going to block the channel, the potassium channel, to exit. So they are not going to exit the cell. They're going to make the potassium stay longer in the cell. Staying longer the potassium means that the relaxation is going to last longer. Okay? Okay. So phenytoin, I'm skipping a few things here. Why? Because there's drug interaction coming later. But I'm just giving you exactly what I want you to know, exactly what mostly they're going to ask you. All right, so let's see. Class 4, we have the verapamil. What is the verapamil? Verapamil is a calcium channel blocker. Okay, diltiazem. So verapamil is mostly what they like to ask you. Verapamil. Verapamil. Adenosine and digoxin. Okay, especially the digoxin is the one class 5. We don't know exactly the mechanism of action, but they actually produce chronotropic negative. That is the only thing I want you to remember. Remember, digoxin can be used for heart failure and can be used for arrhythmias. Okay. All right. So that's it about antiarrhythmics. Very simple. Any question?
No.
No.
Okay. So let's have a few minutes break, and we are going to finish with the last part that is very interesting. And yeah, so I think we are on time. All right, so I will see you in 10 minutes. No, 10 minutes. What 10 minutes? 4 minutes, 1:40. Okay.
Okay. Thank you, Dr. J.
Thank you.
Okay.
Okay, so let's finish. So it looks like the PowerPoint was different. I just upload the version we are talking about. Okay, sorry for that. Okay, so let's keep going. Where is the? Okay, so let's talk about the anticoagulants. Okay, anticoagulants is going to be important because they are going to be used in many reasons, right? From patients who are going to have some DVTs or arrhythmias, atrial fibrillation, myocardial infarction, anginas. So they are going to heart failure. Heart failure. Remember, the heart failure, you can slow down the blood and they can produce clots. So that we are going to use anticoagulants. For this, I want just to remember a few things here. Number one, we have very simple, very fast. Clot is equal to, say, thrombus, right? Thrombus. Plural is called thrombi, plural. Okay, thrombus. When the thrombus is traveling, a traveling thrombus is called embolus. We already know. Then the clot is formed by three structures: the red blood cells plus the platelets plus the fibrin. So the clot is not clot if they don't have these three components. Huh? They must have the red blood cells, the platelets, and the fibrin. All right, so the platelets are going to be affected basically by we call the primary hemostasia. Hemostasia. I didn't say homeostasis, hemostasia. And the fibrin is the secondary hemostasia. I didn't say homeostasis, I said hemostasia. The primary hemostasia, what is going to affect are the platelets. And which medication is going to do that are going to be the NSAIDs. The NSAIDs. The NSAIDs, they have antiplaquetary activity. And the secondary hemostasia are going to be basically by the what? By the heparin, okay, called the warfarin, or the other one is warfarin. So heparin and warfarin is different. Huh? Warfarin is called the Coumadin. Heparin basically is going to be subcutaneous and IV, and warfarin is PO. So there is no warfarin intramuscular. So heparin and warfarin. So what they are going to do is basically going to affect the secondary hemostasia. All right, so when you have, especially in some cases, we use dual activity. We use something that blocks the primary and the secondary hemostasia. Depends. All right, so that is the general thing. Let's keep going. All right, so anticoagulants agent that prevent thrombus formation but do not dissolve or stabilize existing thrombus. Okay, so that is important to let you know. Anticoagulants, we are talking about the heparin and the warfarin. And these drugs are going to basically prevent the new formation of clots. That is huge, okay? So if you have a clot already in your vessel, you give heparin or warfarin, the clot is going to stay there. It's not going to happen anything because it's already formed. And the warfarin and the heparin do not dissolve the already formed clots. You okay with that? All right. So just remember that. So the anticoagulants, the warfarin or heparin, are going to prevent the new formation of clots. But this is not going to do anything of the already existent clots. Okay? Okay?
Yes.
Okay. All right, so here we have the laboratory test of thromboembolic disease. Okay. Control warfarin therapy. You need to remember the mechanism of action of the warfarin. The warfarin, the mnemonic I would like you to remember is the kept the cow. Kept the cow. You like cows? Charlize, I know you told me once you like cows, right? See, nobody wants to talk to me. All right.
We love cows.
I like cows.
Okay, it's too late. Okay. Later, tell me about the cows. All right, that's fine. All right, so the potassium, what is the warfarin? Coumadin means, CO means coumadin. W means warfarin. Coumadin and warfarin. So it's the same. What they're going to do is to compete with the vitamin K. Compete with the vitamin K. Where is the vitamin K happening? So in some of these, we have, this is the coagulation factors. Coagulation factors 12, 11, 9. We have the 10 somewhere, the 9. Where's the 10? The Christmas, where is the Christmas one? Okay, so 8. So what happening is that you have from 12, they're going to form into 1 here. The coagulation factor 1, that is the fibrin. The fibrin. In these chemical reactions are going to participate the potassium, the vitamin K, the vitamin K, the vitamin K. So vitamin K. And what is doing the coumadin and the warfarin are going to block the vitamin K, the vitamin K. Blocking the vitamin K, you do not produce fibrin, and you have risk for bleeding. Okay? All right. All right, so one thing here I forgot to mention here. Okay. For the heparin and for the coumadin or warfarin, remember, kept the cow. And remember that kept the cow, CO, coumadin, W, warfarin, and it's going to compete with the vitamin K. And what is the laboratory test? Kept. PT is the PT. PT is kept the cow. Coumadin or warfarin are going to use the PT. And the heparin is going to be the PTT. PTT. The partial thromboplastin time and the prothrombin time are going to be the coumadin. So we have PT and PTT. You just need to remember, and I'm sure you did in MedSearch this, is that coumadin and warfarin is measured with the INR. INR. The INR is the international or internationalized international normal ratio. And what is the INR? The INR is the PT of the patient over the PT of the laboratory test. The normal values of PT let's start with this. The PT values is going to be less than 15 seconds. That is the normal. The PTT is going to be less than 32 seconds. How to remember that? PT, 2 letters, 15. PTT, 3 letters, 32. Okay? So now, the INR is used for coumadin and warfarin. Is the PT of the patient. How to remember that? Who is the first? Who's first? The patient. So PT of the patient over the PT of the laboratory test. And the INR values are going to be between 1 to 1.5. If you have more than 1.5, is basically an increase of bleeding. You have less than 1 increase of clots. Okay?
Yes.
Yes.
Okay. All right. So when you're taking the PT, sorry, this is the INR. So I said 1 to 1.5. Yeah, but it can be now. It depends on the lab, right? But it's basically 1 to 1.5. So now, when you are taking warfarin already, the levels of the INR are going to be higher, and with that we consider normal high. So this question for the exam, if you are having you don't have warfarin, your INR should be 1 to 1.5. But if you are being under treatment, your new normal value will be between 2 to 3. That is considered normal. Okay?
Yes.
Yes.
Okay. All right. So now one of the tests. So just remember, when you are having problems with myocardial infarction, the typical lab test is the troponin. Troponin. But when you have clots, is the D dimer. Is the D dimer. Is the D dimer. Okay, the D dimer. So you have a clot, you suspect you have a stroke, suspect you have of the clot, right? DVTs, they are going to check a D dimer. So you have a D dimer what is a D dimer? D dimer, when you have normally a clot in your vessels, that clot is going to be considered young clot when it's less than 2 weeks. And that is the most dangerous clot. Why? Because the clots are going to get attached to the endothelium, but at the beginning, this attached clot is going to be very weak. After 2 weeks, the clot start to get attached to the walls of the vessel stronger. So you have a clot that is attached to the vessels for many years. So you need be aware of that. And normally, what is the body trying to do is to try to dissolve naturally the clot. So the body is trying to dissolve the clot. When this dissolve, are going to release a protein, and this protein can be read by the lab test. Which protein is this? Is the D dimer. So if you have presence of D dimer, means that there is a presence of a clot. The body trying to dissolve. There is a clot in conclusion. Okay, so we have the platelet inhibitions. The platelet inhibitors are going to be the aspirin. As you already remember from your previous lectures, previous courses, the aspirin is the king, the queen of the platelet inhibition. The aspirin itself are going to last about 7 days. 7 days. The doses of aspirin with heart failure, angina, you start that in the first day, 325 milligrams. 325 milligrams. And the next day, you're going to use 81 milligrams of aspirin. And that for maintenance, are going to last for about a year until you have checkups and all that. All right. So enteric-coated aspirin is being taken with 6 and 8 ounces of water in order to decrease the intestinal upset. This is coming, I'm telling you. Okay? Enteric-coated tablets cannot chew it. So that is pharmacokinetic, pharmaco1. You already know that. So you have risk for bleeding. This risk for bleeding can be internal or external. How you can check bleeding in the patient? You check bleeding, we have gums. The gums are going to have some blood, right? So in this case, listen to this, what I'm going to say. So you're not going to brush the teeth. You're going to basically rinse the teeth, because otherwise they can produce bleeding. Okay, so we have the heparin. You already know. I already told you. The heparin is going to be can be IV or can be IV or subcutaneous. Correct? When it's subcutaneous, the needle should be 1/2 to 3/4 of an inch, okay, times 25 to 28. How you pronounce gauge? How thicker is this the needle? Okay, so that is the needle that you need to use in that range, 1/2 to 3/8 of an inch, and the gauge is going. The diameter is going to be between 25 to 28, very thin. You remember, the lower the number of the gauge, the more bigger diameter it's going to have. Okay. Okay. Oh, there you are. Why I have to. All right. So use writing. All right. So listen. What is the antidote for warfarin?
Vitamin K.
Vitamin K. Vitamin K. Where are mostly the vitamin K in your diet? Green leaves, chard, spinach, lard. No, lard. No. What is the spinach? Chard, and the other one is the other
Kale.
green. Kale. Yes, always avoid the kale. Kale. They have very rich in what in vitamin K. So you need to be careful if you eat this too much, right? So why? Because if you take warfarin to block the vitamin K and you eat a lot of kale, spinach, and chard, that is going to decrease the effectiveness of the medication. Make sense, right?
Yes.
Okay. Okay. So what is the antidote for heparin? The antidote for heparin, write it down for your book of is the protamine sulfate. Protamine sulfate is the antidote for heparin. Okay? There you are. The heparin, the protamine sulfate is the heparin antidote. All right, so we have enoxaparin. I'm not going to go on that. So it's the same thing I was mentioned. I want to go over TPA. Where is the TPA? All right. So that is called the thrombolytics. Thrombolytics, okay? So we have anticoagulants and we have thrombolytics. Anticoagulants, the heparin, the warfarin, Coumadin, those do not destroy or dissolve the already existing clots. But we have other medications that are called the TPA or the thrombolytics. Thrombolytics, thromboclot, lytics, destruction, is going to dissolve the clot. Okay? This basically is, I call the Drano of the body. The Drano. Why? Because the Drano dissolve everything and make the flow passing. Right? Exactly the same what is doing the fibrinolytics is going to be the TPA. TPA, we have others that is the streptokinase. That is an old one. The urokinase is not in use anymore. So just remember, place. Those are fibrinolytics. But the one I want you to remember, and with that we finish, is the TPA, is the tissue plasminogen activator. This is what I call the super Drano. That is what they use. If you have myocardial infarction caused by a clot, if you have a DVT and you have a stroke that is suspiciously caused by a clot, they're going to give you the TPA. TPA are going to basically dissolve the clots. Okay, so this TPA, when you give in excess, they can produce bleeding. So the anticoagulants are going in excess can produce bleeding. The fibrinolytics are going to produce bleeding, internal or external, either way. And the antidote for the tissue plasminogen or TPA are going to be, question for the exam, the isominocaproic. Isominocaproic acid. Okay?
Yes.
Yes.
Okay.
Yeah.
So for this class, I want you to just make notes about this. Is that heparin subcutaneous, the needle that you're going to use? We have, remember, the warfarin and coumadin can be affected by the GGG. Remember the GGG? Ginger, ginkgo biloba, green tea, etc. Right? Ginseng. Okay. The antidote for the TPA, the antidote for heparin, okay. So basically, is that what I want you to know for this class? Oh my God, what happened? Is the weather or something? All right, muchas gracias. Thank you so much. What time
Thank
is
you,
it?
Dr. G.
Thank you, Dr. G.
Thank you.
Thank you, Dr. J.
Now everybody participate, and now I say goodbye. Everybody fly like a rocket. Okay, bye. See you.
Bye. Thank you,
Bye.
Doctor.
Have a good Friday.
Bye.
Thank you.
Bye.
Thank you.